Lateralis, a very important point is there in the skull. This is called the Pterion. So this is the Pterion is the area where four bones they meet together. One is the frontal, the parietal, temporal, and greater wing of the sphenoid bone. So this Pterion is very much clinically important. Coronal suture meets here with the temporal bone and the squamous part of the temporal bone meet with the occipital bone with the lambdoid suture. So this part is called the greater wing of sphenoid. Most of the sphenoid bone is inside the skull, but only a small part comes out to form the Pterion, where the frontal, parietal, temporal, and greater wing, the four bones they meet. So this H shape, it resembles alphabet H. The Pterion, the sutural lines of the joints. And this Pterion is clinically important because of the important structures lying inside the skull, touching this Pterion. So if we see the Pterion, the diploid, there is the outer table and inner table of the compact bone, and in between there is a sandwich is the spongy bone. So if you concentrate on this area, the diploid is cut, outside the skull is the scalp with all 5 layers touching the surface, hairy part of the skin, but just inside the inner table, touching the inner table of the diploid is the two inseparable layers of the dura mater. Outer, which is touching the inner table of the bone, the skull bone, is called the endosteal layer, and the inner one is called the meningeal layer because it is near the meninges, that is the arachnoid and the pia. Then inside it, inside the touching the inner surface of the meningeal layer of the dura mater is the arachnoid mater with spider web-like projections. That's why its name is derived, arachnoid, from arachnida. And this arachnoid projections, they touch the surface of the delicate membrane that is called the pia mater. And as we know, the pia mater is touching the surface of the brain. That is the forebrain, midbrain, hindbrain. Every part of the brain is covered by the pia mater. So this is the grey matter that is called the cerebral cortex. At this point, cerebral cortex lies inside, and these are the white fibers, the commissural, projection, and the association fibers. They have done the white matter of cerebrum. So this is the coronal section of the brain with the skull as well as the 3 meninges. So this picture should be very clear. Now there are spaces. The space between the inner table of the dura mater, the diploid, and the dura mater is called the extradural space. Extradural space. Extra means outside the dura but inside the skull bone. Then there is also a space between the very pencil space. Only tip of your pencil can go through this space between the arachnoid meter and meningeal layer of the dura mater. Again a space is there. This space is defined as the subdural space. Sub means below. Dura means dura. It only admits the tip of your pen or pencil. Very potential. Then comes the arachnoid meter is quite far away from pyometer. It forms a very large cavity that is called the subarachnoid space. Below the arachnoid but above the pia is called the subarachnoid space. Then a space is present with the pyometer and the grey or white matter of the brain. This space is called subpial space. These four spaces they are present, and every space has got some clinical importance that we will discuss whenever a question of the Pterion comes, how to attempt it. First is the extradural space. So extradural space contains the contents of the extradural space. They are middle meningeal vessels. That is middle meningeal artery accompanied by the same name of the vein, middle meningeal vein. As the name suggests, middle meningeal vein. It means artery means it supplies the dura mater, which is rough, tough, and resilient and protective in function, made up of fibrous tissue. Then in between, in the subdural space, very fine capillaries are present, which pierces the meningeal layer of the dura mater and they supply the arachnoid space. So it is a very pencil space, so the blood vessels they are capillary-like, very thin, fine, like your hair. Then the subarachnoid space we all know, here lies the circle of Willis is bathing in this. All the intradural, intracranial venous sinuses, they are all bathing in the CSF, present in the subarachnoid space. All blood vessels, artery and veins supplying the brain, they are present in the subarachnoid space, surrounded by fluid, that is the CSF. Then the subpial space. The subpial space is a potential space, and through this blood vessel they enter the surface of the grey and white matter of the brain. So any branch of the artery goes on the surface of the pyometer, and this artery dips into the grey or the white matter of the brain to some extent, to some distance. The pyometer also accompanies it. It forms a sleeve and it thins out as it goes towards the grey and white matter, and ultimately it merges with the tunica externa of the blood vessels supplying the. So that is the subpial space. So whenever Pterion is important because of the injury. If in the roadside accident, if a person have got the injury at the Pterion point, then serious complications they arise. So for that you have to superimpose your knowledge of the brain with the skull. That which part of the brain touching the which part of the skull. As we know already, we have done the brain. So inside the brain, the largest part of the brain is the cerebrum. Its upper cerebral convex surface is merged with the convexity of this vault or the skull. Then anteriorly comes the frontal lobe, it lies just above here. And below is the temporal lobe. and temporal lobe. This is the pre-occipital notch, and this is the occipital lobe, touching the inside of the tentorium cerebelli, below the tentorium cerebelli in the posterior part. And here, somewhere here lies the lateral sulcus, and this is central sulcus, obliquely running. Anterior to it is the pre-central sulcus, post-central sulcus, the various other sulci and gyri. And here is very important, and opposite the pterion lies the horizontal sulcus and ascending sulcus. And here lie the three areas: pars orbitalis, pars triangularis, and pars opercularis. They lie just inside the pterion of this skull. Another thing you already know, that deep in the lateral sulcus lies the deep middle cerebral vein. In the same sulcus that is called the lateral sulcus is also called the sulcus of the Sylvian sulcus. Also lies the one of the major artery of the circle of Willis, that is the middle cerebral artery. Both are the content of the lateral sulcus. And middle cerebral artery is very important because the diameter of the middle cerebral artery is equal to the diameter of the internal carotid artery. The posterior cerebral and anterior cerebral is thin, but it is geometrical. So these are the contents and the structures present we already know. Now the middle cerebral artery and deep middle cerebral vein, they lie in the lateral sulcus. Both are very, very important because they contain a large amount of the blood, and they are covered by extra amount of the CSF, which make these vessels away from the skull. Skull is very soft, the brain is very soft, but the first enemy of the brain is the skull itself, which is protecting it. Because bone is the hardest tissue of the body. So brain lies very, very close to its enemy, that is the skull. So whenever there is a head injury, the impact of the injury on the pterion, if there is a pterion is fractured. If a patient comes with the head injury and in the CT scan we see that there is a fracture of the bone at the pterion area, then what possible problem a patient can show, only anatomy tells that what the patient can present with what problems. Number one problem is the patient is suffering from extradural hematoma. EDH. Patient comes with the EDH, that is the extradural hematoma, because of the injuries here. And what lies just below the skull and the dura mater? Middle meningeal vessels. So between the fracture fragments of the bone, these arteries and the veins can be ruptured. They are damaged, leading to the bleeding. And this blood is collected in this potential space that is called extradural, means outside the dura but inside. So this collection of blood is called the hematoma. Heme and toma means like a tumor. That is called the extradural hematoma. Now the bleeding is continuous. If it is arterial, it is continuous. Now this hematoma is enlarging inside. It doesn't enlarge outside externally because there is a bone. Where it will extend? Internally, in all directions, and it will throw the dura mater inside. As we know, arachnoid is also with this, so arachnoid is also bulged out internally because brain is soft. And similarly, this bulge of the arachnoid mater will occupy the subarachnoid space, which is quite big space. So this is the hematoma which is increasing in size and pushing the dura mater and the arachnoid mater in the subarachnoid space. And it will increase in size with the duration of the time. Ultimately, this hematoma may reach up to the brain. It will touch the surface of the brain, traversing the whole of the diameter or the length of the subarachnoid space. When it touches the brain, then whichever part it is touching will go out of order, and patient will present with the complications depending upon which area is pressed, this hematoma. If it is in the Pterion area, we know which functional area lies here. This hematoma is there. So if the patient come early, before 24 hours, and the CT scan showing that the hematoma is extradural, we immediately admit the patient, because we know patient may die because of the idiot, because it is progressive. Middle meningeal vessels, they are big, and they are the branch of the maxillary artery. Maxillary artery is the branch of the external carotid. External carotid is the branch of common carotid, and common carotid is the branch of arc of the aorta. It means if the middle meningeal artery is opened here, it means arc of the aorta, ascending aorta, left ventricle is opened. Whole of the ejection of the blood comes into this. It's a very progressive phenomenon. Any doctor attending the CT scan, seeing it and seeing a very small hematoma is there, and he or she tell the patient that no problem, go at home. Patient we have seen that patient have died at home after 24 hours or 48 hours. This is the plenty. So this hematoma will increase in size, it will press the brain, and the symptoms they appear. As we know, here lies the first, below the meninges, in the subarachnoid space, what lies? Middle cerebral artery and middle cerebral vein. So this extradural hematoma will press the blood vessels, occlude their circulation. If the patient is diagnosed earlier, if the hematoma is small in size, we know it may damage. Immediately we shift the patient to the operation table, and what we do to evacuate or to remove this hematoma, we will do the craniotomy. We do the craniotomy, or it is called the burr hole. Burr hole craniotomy is done. So here we will make the hole in the skull just above the Pterion. But the scalp is cut. The scalp cutting is very important. It is cut not below, it is cut like this. Half moon shape scalp cut is there. And we put the flap downward. And we expose the skull. And with the chisel, we will make a hole in the skull. And this is called the burr hole, the craniotomy. And we put the catheter here, and we withdraw the hematoma. Patient will be immediately recovered right on the operation table. It doesn't require any anesthesia. Patient is awake. We don't give any anesthesia. Only local anesthesia is given, because already he is suffering from head injury. Any anesthesia will dip his parameters. He may die on the table. So this is the procedure if patient come earlier. But if patient is ignored or he is late to come to a doctor, this progressive increase in size, and first of all, the blood vessels here, the subarachnoid space is already here around the lateral sulcus is large. A large cushion-like enlargement of the subarachnoid space is already protecting these two blood vessels. And this cushion-like CSF-filled sac is called cistern of the lateral sulcus. You have done it. Enumerate, the question is very important. Enumerate the various cisterns. So cisterns, they are the fluid-filled sac of the CSF. and they are present at the vital points of the brain on the inferior surface. For example, it is present around the optic chiasma, it is present in the interpeduncular fossa, that is called the cisterna interpeduncularis, because in the interpeduncular fossa, circle of Willis is a very vital structure is present. It is also present on the ventral surface of the basilar sulcus of the pons, because a very important basilar artery is present there. It has to protect that. Cisterns. Then it is present around the cerebellomedullary angle posteriorly, because medulla is a very important part of the brain, because it contains respiratory and the cardiac center. You have done in the physiology, central regulation of the blood pressure and the apnea and the respiration. Medulla is very important. So wherever the important structures are present, blood vessels or the part of the gray and white matter, the God has given a large collection of the CSF. They are called the cushions or the cisterns, we name them. They will keep these structures as away from the skull as possible, because skull is the first enemy of the soft brain. That is called the cisterns. Now you are all sitting on the wooden or a hard object. Your back may be having pain for 3 hours sitting. So if we put a small cushion here, you will be comfortable. So what is that cushion is doing? It is keeping your body away from the back wood, hard wood. Same is the system. So cisterns are the cushions made up of the CSF field, which keeps the structures away from the skull. That is how you exemplify what are the cisterns and what is their need in the brain. So this is the first is the cistern. So it will press the cistern. But if the impact of the injury is so big that the dura mater may be tear, there will be tear in the dura mater. With the dura mater tear, what happens? The arachnoid matter is also very intimately touching it. Arachnoid is also cut. With the cutting of the arachnoid matter, what will happen? To the fracture line, CSF is coming out. CSF is leaked from the Pterion, because we know here lies a large collection of this cistern of the lateral sulcus, or also called the Sylvian cistern. So loss of the CSF is the first point. Patient says that I am having watery discharge from my wound. So, and when it is coming out, bacteria will go from the same route inside and patient may die. Very quick binary fission of the bacteria grows in the CSF, because it is a nutrition fluid. So first is the leakage of the CSF. CSF will be lost from the CNS. Patient may die because of the loss of the CSF only. So that is the first problem, that is the CSF leakage from the Sylvian sulcus or cistern. If it is okay, then what will happen? The hematoma will press. And hematoma will press the brain, and this extradural hematoma, what it will press? First the blood vessels. And both the blood vessels, they will be obstructed, as if you have put a foot on the pipe which is draining the watering the lawn. So if you stand there, what will happen? Water will stop and whole of that area remains dry. Same is here. If the hematoma is pressing the middle cerebral artery vessels, the blood won't go. And where it goes? It is supplying, it is running in the sulci, pre-septal sulcus, post-septal sulcus. Anteriorly, if you remember the diagram of arterial supply of the middle cerebral artery area. So this artery, the middle cerebral, is the largest and supplying a large area of the cerebrum up to the parieto-occipital sulcus, if you remember this diagram. All these areas having functional area will be 0. Now there is a long list you can write down, patient present with. If you know the functional areas, then only you can answer this question. So patient present with the CSF leakage, that may cause the death or encephalitis, because bacteria will go inside directly into the brain, and the encephalitis is the ultimate death. If she survives, it will press the blood vessels and it lead to the functional areas will be deranged. And the first area is the Broca's area, so patient come with the speech loss. That is called the aphonia. Loss of the speech called the aphonia. Patient can't phone. You have to remember. Speechless. But only to the dominant hemisphere. In the right-handed person, if the Pterion is damaged on the left side, then only he will have the speech loss. But the patient, if he is right-handed, if the Pterion of the same side will be damaged and Broca's area will be damaged, the speech is spared. He can speak because this is only dominant hemisphere function. Then we know here like the precentral gyrus. Up to here, this is the precentral homunculus. Postcentral gyrus also homunculus. The motor area, the sensory area will be damaged. The patient will come, number one, complete speech loss. Number two, paralysis of the muscles of half of the face, neck, upper limb, thorax and abdomen. Lower limb will be spared because this is supplied by anterior cerebral artery. Only middle cerebral is involved in the Pterion. Who will write down the hemiplegia will get 0. Because he doesn't know the lower limb comes under the supply of anterior cerebral. This is called the watershed zones. Where the anterior cerebral and middle meet, this line is called watershed zones. Because cerebral arteries, they are end arteries. They do not enosmote. Every artery is selfish artery, it only supplies its own territory. That is the problem, same as we have done the coronary artery. That lead to myocardial infarction, here it lead to cerebral infarction. That is called the stroke or CVA, cardio cerebrovascular accident. CVA. So this is the problem. Number two, patient come with the motor loss of from face to the abdomen. Number three, same is the sensory skin. Postcentral gyrus is representing skin. The skin of the half of the face, neck, upper limb, thorax, abdomen, to this area. So body represented upside down. We call the homunculus representation. S for skin, M for muscles. So loss of the blood supply to the precentral gyrus from this point to this point lead to the paralysis of the muscle and lead to this postcentral gyrus lead to the sensory loss. General sensory loss of the skin of the up to the abdomen. That is cause of pain, temperature, pressure and touch. We postcentral gyrus is for the sensory. Then anterior area, this area. Which area function area is there? This is called conjugate movement of the eye field area. Conjugate movements of the eye will be lost. Then what is this area? Supplying this is the personality, reasoning, emotional behavior, memory, judgment, intelligence, all will be 0 because this area is called the Prem-G area. So patient, you can write on the long list presentation of patient. Then just below the postcentral gyrus is the parietal lobe. Which area lies over here? Very favorite area. That is taste area. Loss of taste. Loss of taste will be there. Then just in the middle of the superior temporal gyrus, which area lies over here? Temporal lobe is a functional area, auditory area, hearing area. Patient will be the hearing loss. Because this comes under the territory of middle cerebral artery. Then the angular gyrus, just at the upfront portion of the lateral sulcus. Which area lies over here? It's called Wernicke's area. Sensory speech area will be lost. This area, inferior parietal gyrus. What is the function of this area, parietal area? Is the loss of stereognosis, recognition of the objects while your eyes are closed. You can only attempt this question if you know the functional areas because it is not given in your book. This is the common sense. So this is a very tricky question. Pterion, 10 pages you can fill only on the Pterion. It's so extensive. So this is the blood vessel is involved and progressive is there. And ultimately below. Now it will press further